Hello, everyone. My name is Alduber Benitez, a student in the Psychiatric Nursing Program for Psychiatric Mental Health Practitioners at Herzing University. I'm working in outpatient mental health. Today, I want to walk through how I would manage a psychiatric crisis with a long-term patient. I've been seeing a 45-year-old male with a history of major depressive disorder and prior pornography addiction. He presents today visibly distraught, reporting that he recently discovered his wife's infidelity. She left him, took their children, and moved in with the man she was having an affair with. He found a note explaining everything and hasn't had contact with his children in over a month. He's on citalopram 20 milligrams daily, which had been effective for years. However, he now admits to daily alcohol use and active suicidal ideation with a plan to shoot himself. When asked what's kept him from acting, he says, "My kids, but I'm losing hope I'll ever see or talk to them again. My immediate priorities are 1. Ensure safety. This patient is at imminent risk of suicide. He reports active suicidal ideation, a specific plan, access to means, a firearm, worsening functional decline, not working, substance use, hopelessness and isolation. Given these factors, active suicidal ideation, a specific plan involving a firearm, recent acute psychosocial stressors, alcohol misuse, loss of protective factors, and significant functional decline, I would initiate an emergency psychiatric evaluation immediately. This is a psychiatric emergency, and the patient cannot be allowed to leave the office under any circumstance due to the risk of imminent self-harm. My first step would be to ensure the patient remains calm and safe in a quiet, private room under supervision if possible. I would maintain a non-judgmental, supportive tone and let the patient know I am here to help and take their safety seriously. Next, I would immediately contact the on-call crisis response team affiliated with my clinic or community mental health center. If our local mobile crisis unit is available, I would request an urgent face-to-face evaluation in the office to determine the need for psychiatric hospitalization. If no crisis team is available, or if the situation escalates, I would call 911 and request law enforcement or EMS transport for a psychiatric emergency. When speaking to dispatch, I would clearly state, throughout this process, I would stay with the patient or assign a staff member to remain with them until emergency responders arrive. I would also work to de-escalate anxiety and reduce shame, acknowledging the intensity of his emotions while reassuring him that he is not alone and help is on the way. By taking these steps, I would be fulfilling my legal and ethical obligation to protect patient safety in accordance with psychiatric emergency protocols and state mental health laws. Lethal means counseling. While awaiting crisis services, I would calmly assess firearm access. Do you currently have access to the gun you mentioned? Is it in your home? If he confirms access, I'd attempt lethal means reduction, asking if he'd be willing to have a friend or family member temporarily remove it or store it safely. If not, this only reinforces the need for immediate inpatient stabilization. 2. Involve support systems, if safe. If he has any trusted support, such as a sibling, friend, or pastor, I would ask for permission to contact them. He may feel isolated, and even a single supportive connection can be a protective factor. 3. Documentation and risk assessment. I would thoroughly document his suicidal ideation and plan protective factors, his children, aggravating factors, alcohol, access to means, job loss, my clinical decision to refer for inpatient hospitalization under involuntary hold if necessary for safety. 4. Post-crisis follow-up plan. Once stabilized, the treatment plan would likely include medication reassessment, current medication, citalopram 20 mg PO daily reassessment actions, evaluate therapeutic response and side effects. If there is an inadequate response after 4 to 6 weeks, consider titration, increase to citalopram 40 mg PO daily, as tolerated, maximum recommended dose for adults. Switching antidepressant class. If citalopram is ineffective or poorly tolerated, consider transitioning to another antidepressant class such as serotonin norepinephrine reuptake inhibitor, SNRI. Example, venlafaxine, XR 37.5 mg PO daily, titrate up to 150 mg PO daily as needed, atypical antidepressant. Example, bupropion, SR 150 mg PO daily, may increase to 150 mg after 3 days if well tolerated. always monitor for changes in mood, suicidal ideation, and side effects with any medication adjustment. Involve the patient and, if appropriate, family in shared decision making. O alcohol use intervention. Expert, possible referral to addiction services or trauma-informed therapy, focused on betrayal, trauma, grief, and fatherhood, or psychoeducation. Emphasize that his emotional pain is valid and that treatment is available and effective. Crises like this point out the importance of establishing strong therapeutic rapport and trust early in the treatment relationship. When patients feel seen, heard, and supported over time, they are more likely to disclose thoughts of self-harm, substance use, or feelings of hopelessness, especially during moments of emotional collapse. As an outpatient psychiatric provider, my role extends beyond managing medications and monitoring symptoms. It includes cultivating a safe, judgment-free space where patients can be vulnerable and speak honestly about their struggles. This foundation of trust is what enables early identification of red flags, such as increased isolation, functional decline, or expressions of hopelessness that may precede a psychiatric emergency. In moments like this, clinical intuition must be paired with swift, evidence-based action. Recognizing the difference between passive thoughts of self-harm and an imminent plan is essential. Once imminent risk is identified, it is my ethical and professional duty to intervene decisively and compassionately, mobilizing the appropriate emergency resources, protecting the patient's dignity, and preventing harm. Moreover, these moments of crisis serve as powerful reminders that mental illness often fluctuates and that even patients who have been stable for years can rapidly decompensate under extreme stress. That's why continued engagement, careful monitoring, and proactive crisis planning are integral parts of outpatient psychiatric care. Ultimately, my goal is to ensure that each patient not only survives a mental health crisis, but is guided back toward hope, stability, and long-term recovery with the support of a provider they can trust. Thank you for having me and have a nice day. Don't forget to subscribe to this channel for more information about managing psychiatric crises.